everyone, I'm Dr. Lahari this side, and today's lecture is a combination of topics on TMJ imaging, salivary gland imaging, and imaging of the maxillary sinus. The learning outcomes would be sectioned into TMJ imaging separately, and then for the salivary gland, followed by maxillary sinus. To start off with, to explain the normal anatomy of TMJ, list TMJ imaging techniques, discuss indications of TMJ imaging, and demonstrate the technique for TMJ imaging. So let's start with TMJ disorders imaging. So this is just to summarize the anatomy of the temporomandibular joint. It's important to remember that the joint comprises of the head of the condyle and then part of the articular surface and the eminence, and then there is an interarticular disc which is a fibrocartilaginous structure. So, for performing diagnostic imaging of the TMJ, it may be necessary to supplement it with clinical examination. It's important to understand that specifically for TMJ disorders, thorough clinical examination and arriving a diagnosis is utmost importance before diagnostic or diagnostic procedures are advised. So the application of diagnostic imaging in TMJ disorders would be primarily to look at osseous abnormalities, infections, in cases of history of trauma, significant dysfunction or alteration of range of motion, or significant changes in occlusion. Again, it's important to remember that minor TMJ dysfunctions or alterations in range of motions do not really warrant diagnostic imaging. And both joints must be imaged for comparison. For osseous structures of TMJ, the imaging modality that is preferred would be either panoramic imaging or more detailed and higher resolution images like CBCT or multi-detector CT images. Whereas for soft tissue of the joints, it is best imaged with MRI, especially in conditions like disc displacement with TMJ, pain and dysfunction, and to supplement osseous imaging in cases of neoplasm or infection. The conventional radiographs like the transcranial, transorbital, and transpharyngeal views, like the ones I've shown here, are obsolete now. And panoramic view is primarily used to get a broad overview of anatomical structures of the TMJ. It is primarily panoramic view can help to rule out gross disease like asymmetries, extensive erosion, neoplasm, fracture, or large osteophytes. Minor details are difficult to delineate on panoramic view, and it may be less reliable to solely base your diagnosis on a panoramic view, especially for the TMJ, because it has thicker image layers and an oblique distorted view of the TMJ. This is an extension of the panoramic view, also with the same equipment, which is called as a TMJ open and closed view, which gives you an idea of the location of the TM joint when the jaw is open as well as when the jaw is closed. The CT scan of a TMJ again is reserved for serious diseases like neoplasia of the TM joint, and can give a very good view of the osseous component of the TMJ. CBCT scan also of the TM joint would be reserved for osseous component viewing of the TMJ, where a disease process is suspected and a clearer view of the joint is required. On the other hand, the MRI of the TMJ is specifically reserved to view the disc. This is a comparison of a normal disc on the MRI and a displaced disc. You can see the soft tissue component which is displaced anterior to the condyle, the bony condyle here. And this is the MRI view of a TM joint. Arthroscopy of the TMJ, which is a procedure where injection of injection of dye is done, and or you can view with an endoscopic view of the TMJ, is less opted these days, and it is again a very painful procedure and a very skill requiring or technique sensitive procedure. Arthrography is when dye is injected into the TM joint. Radio opaque dye is injected, it's contrast media to evaluate the joint space. Again, like I told you, it is of less significance these days and is more replaced by the MRI and CT images. Moving on to the salivary gland disorder imaging. Imaging of the salivary glands is primarily done to diagnose and plan management as well as follow up of patients having salivary gland disorders. There are various imaging techniques that have been adopted to visualize the salivary glands, and we will go through each one of these in detail. The learning outcomes would be to list salivary gland diseases, imaging, and its radiologic appearances, and to discuss differential diagnosis of salivary gland diseases, xylography procedure, and xylography techniques. Let's talk about plain images first. These plain images, I mean plain radiographs. Generally, you use intraoral occlusal views to view of when you are suspecting siloliths in the submandibular duct, or panoramic view when you're expecting siloliths in the parotid and submandibular gland. So mind you, there is a difference in what is written over here. What you're seeing on this image is a cropped panoramic view, is a Staphnase bone cavity. Reason I've mentioned this here is it's not a true cyst. It's a corticated defect in the posterior mandible below the inferior dental canal, and it may contain part of the submandibular gland. A silolith is a common occurrence in the submandibular salivary duct. We are aware of the reasons why the Wharton's duct is a more common location is because of its tortuous course and location of the duct, and also the components of the saliva that is secreted by the submandibular salivary gland itself. So siloliths can vary in their radio opacification based on the calcification and the density. The X-ray that is shown here is a cross-sectional occlusal view of the mandible, and you can see that there are few radio opacities in the salivary duct, which is the proximal component of the duct, very close to the orifice of the duct. Ultrasonography, high resolution ultrasonography in specific, is a very important method of imaging the salivary glands. Initial assessment of the parotid and submandibular salivary glands can be done with ultrasonography. It is useful for viewing superficial and abnormalities. It is also useful for differentiating cysts from neoplasms and benign from malignant lesions. Ultrasonography is also of use to guide biopsy and advise further imaging choices. The advantages of ultrasonography would be safety because it does not have any radiation involved. Again, the salivary glands are easily accessible, and any calcification within the gland can be noticed, as well as details of the presence of the any anomalies as well as a neoplasm can be noted down. So this is an example of how the parotid looks on ultrasonography, and also color Doppler has been applied, which gives you a clear idea of how the facial artery and its branches appear, and how the submandibular gland appears, as well as how the parotid appears on the ultrasonography. Multi-detector computed tomography is used to display both soft and hard tissue windows to view the salivary glands and surrounding structures. The image viewing after administration of contrast dye gives an hyperdense appearance and is very useful in identifying and diagnosing inflammatory conditions, neoplasia, and lymph node involvement. This is a case where you're seeing a plunging ranula, which is a large space occupying mass seen on the floor of the mouth. It is a well circumscribed cystic lesion predominantly occupying the left submandibular space, causing a mass defect or effect on the submandibular gland. So you can see that the gland has been pushed to one corner, and you can see a large ranula, which is a plunging ranula. CT scan can also be a scout image over which PET scans can be done. This is an example of a squamous cell carcinoma involving the left sublingual space, and an axial contrast enhanced CT image shows homogeneity along with the left sublingual space. And in B, this is an image of PET CT scan. Magnetic resonance imaging of salivary glands would be the image of choice for space occupying lesions such as cysts and neoplasia. The soft tissue contrast is superior, and intravenous gadolinium contrast agents have to be injected into the intravenously so that you can observe perineural and intracranial spread of disease more clearly. This is the normal appearance of a sublingual and submandibular space, and the appearance of the sublingual gland on MRI, as well as the submandibular gland bilaterally on the MRI. And this is just a diagrammatic representation of how the gland would look like on MRI. This is an example of an adenoid cystic carcinoma of the sublingual salivary gland. This is the mass that you're able to see pointed with the white arrow mark. The This image in the sublingual space, it's demonstrating a lobulated mass which is of a high T2 signal and a low T1 signal. It's actually enlarging and distorting the entire left sublingual gland. Also, there is enhancement which is diffuse post contrast. This is an image after the contrast dye has been applied. Silography is a procedure that was first performed in 1902. It is an imaging technique exclusively used for the parotid and submandibular salivary glands. Silography involves infusion of the gland ductal system with an iodinated contrast agent, and then imaging the gland with projection imaging, that is plain radiographs, fluoroscopy, CT, or CBCT. Silography is the only imaging technique that can assess both morphology and function of the glands at the same time, and that's something very important and unique about silography. The indications for silography would be chronic inflammatory conditions like obstructions of the ductal system, and contraindications would be acute infections or in cases of immediately anticipated thyroid function test, because the iodine in the contrast agent may interfere with test results. This is how the silography procedure is performed. For example, locating the Stenson's duct opening and retrograde injection of the dye into the ductal system. So, the example of radiographs taken after the dye is injected. This is how normal salivary, submandibular salivary ductal system would look like, the normal ductal architecture. And this pattern is called as a leafless tree pattern in radiology terminology. If there are strictures in the ductal system, this can lead to the appearance which is called as sausage-like appearance. This happens because the dye hasn't flown consistently throughout the ductal system due to the presence of strictures. A conventional silogram demonstrates multiple filling defects within the Wharton's duct in this particular image here. This is consistent with the presence of siloliths, because the silolith obstructs the duct and the dye cannot completely flow into the gland smoothly. Now, this is another patient where you can see pre and post contrast injection silogram images, which this is pre contrast injection, this is post contrast injection, and you it easily demonstrate where the obstruction of the duct is happening is because of a large silolith or a large stone. Silography in Sjogren syndrome is a very important radiographic feature. Sylectasis leads to branchless fruit-laden tree appearance, also called as a cherry blossom appearance. This happens because after the dye is injected, it is retained in the inflamed salivary acini because of sylectasis, and it is unable to flush out the saliva, and hence the dye remains there, giving the appearance of the cherry blossom or branchless fruit laden tree appearance. Here I have included various images in plain radiograph. This is a cropped panoramic image, and this is a lateral skull view. This is images on a CT scan, and this is on the image on a xylography. So post xylography, this is a fluoroscopy image, and CT image and plain images done for after xylography. So like I mentioned to you, after injecting the dye, various methods of imaging can be done to view the effects of the dye in the ductal system. This is the appearance again on a xylogram or after xylography of a normal submandibular salivary gland. You can see the leafless tree appearance, the duct and its entire ductal system and the branches. When there is a foreign body, you will definitely see that there is obstruction. If digital subtraction xylography is performed, this would be the stages of the xylography, and you will be able to see the dye slowly filling out within the ductal system, and it completely fills out here. So this is the injection of the xylography dye. Sialoendoscopy was first used in 1990s. It is slightly different from xylography. In sialoendoscopy, as the name suggests, it is a direct visualization of the parotid and submandibular major ducts. Is minimally invasive. It's a technique which is indicated for diagnosis and management of obstruction, specifically within the ductal system. And silolith retrieval and stricture dilation tools are available, because of which you can see in the picture here, which can help to retrieve especially an obstruction caused by stones within the ductal system. Again, sialoendoscopy is contraindicated in acute inflammations. This is an example of exploration of the Wharton's duct. You can note the diameter of the duct, and it is sufficient for insertion of a surgical endoscope for interventional sialoendoscopy. A lacrimal probe has been used in this duct for correct location purpose, and it is important for you to note the location of the endoscope for accurate insertion as well. Paranasal sinus anomalies and their imaging. The learning outcomes would be to list maxillary antrum disease, intrinsic maxillary disease, extrinsic maxillary antrum diseases, discuss differential diagnosis of both of these type of diseases. The major methods of imaging of the paranasal sinus is a simple maxillary periapical view, which can show you the floor of the maxillary antrum, a panoramic view, which can show you a larger view of the maxillary sinus along with parts of the inferior, posterior, and anterior medial walls. The floor of the maxillary sinus may not be viewed very clearly, for which you might have to rely on more images with higher resolution and 3D imaging like CBCT and multi-detector CT scans, which help you evaluate the sinus diseases and extension of diseases, as well as chronic or recurrent sinusitis. MRI can be used for soft tissues views or soft tissue extension of neoplasm into the sinus, and differentiation of retained fluid secretions from soft tissue mass in the sinus. The range of normal position of the maxillary sinus relative to the premolar and molar teeth is shown in these periapical images. In observe images A to D, you will see that in image A, there is no apparent floor of the maxillary sinus, and you will see in B and C that there is progressively more pneumatization of the alveolar process in B and C. Whereas in D, you will see draping of the maxillary sinus border over the apices of the teeth, and is very, very particularly evident in this case. This is the panoramic image which is showing you of a loculus of the left maxillary sinus draping over the roots, mimicking a benign space occupying lesion, but in fact it's just the maxillary sinus which is appearing like a large cystic area here. The Waters view, also called as paranasal sinus view, gives a very clear appearance of all the sinuses, especially the maxillary frontal sinuses. And here you can see maxillary sinusitis by the air fluid level, which is occupying the entire maxillary sinus on the right side, whereas the left side appears more clearer. This is example of again plain radiographs using a panoramic image to observe a mucus retention phenomenon, which is seen as a radio opaque soft tissue mass within the floor of the sinus. And the image on the right shows you the effect of odontogenic cysts in the maxillary on the maxillary sinus. You can see that the floor of the maxillary sinus is pushed, and the entire cystic cyst has occupied the entire maxillary sinus, with also displacement of the impacted teeth within the cystic space. And you can see that the patient here is having a large swelling over the cheekbone, and specifically the maxillary bone area, with even involvement of the nose. CT scan of the maxillary sinus. This is a coronal view of the maxillary sinuses. Picture A, which is showing you complete opacification of the left sinus and circumferential mucosal thickening of the right sinus. This is mucosal thickening of the sinus space on the right side, and left side is completely opacified. Picture B is a sagittal view of multi-detector CT scan, which is showing you mucositis in the ethmoidal region, or the ethmoidal air cells. Again, views of retention pseudocyst phenomenon. It can be very clearly viewed as a radiopaque soft tissue mass seen in a periapical radiograph or a maxillary sinus radiograph, and this is also seen in a CBCT cropped panoramic generated panoramic image, as well as in the on a CBCT axial image and coronal image as well. CBCT scans again can be used to visualize sinus pathology. This is an image just trying to show you the association of maxillary sinus pathology and healthy teeth. If you look onto the right side, these are roots which are within the maxillary sinus, and there is a pathology in the sinus. And a picture below this shows you roots which are outside the maxillary sinus, and there is a pathology in the sinus. So you were able to make out healthy teeth and their relationship to the pathology. On the other hand, you are seeing a normal sinus floor where the roots are looking like they are protruding into the sinus floor, very close to the sinus floor, and an image of healthy teeth and a healthy normal sinus where the roots are away from the sinus. So it all depends on the size of the sinus and the pneumatization. That means how much amount of air content is there within the sinus, and whether there's a pathology in the sinus, which determines how close the teeth are to the sinus space. So this brings me to the end of this chapter. As always, please go back and refer to the textbook for better understanding of the concept. And like I always tell you, with radiology, the more images you see, the better retention you have, and the better you're able to correlate with the clinical case scenario.